Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast this week. My name is Terry Fletcher. Hope everybody is doing well. Welcome to March. We've had definitely a fun couple of months so far this year, and I finally feel like I'm over that cough that everybody was getting. Luckily, it wasn't the coronavirus, but everybody's had some form of some kind of flu, but I'm just happy to say I'm finally over it. And speaking of that, I wanted to kind of start my episode today with something that's going around on social media. And I actually thought it was a joke and somebody was trying to make a funny about the coronavirus, but it's not. There was a CNN poll run, and I don't always believe everything they say just because of the political climate, but this was a factual poll, and it said that of the 3,000 Americans that they polled, 38% wouldn't buy Corona beer under any circumstances, and that was a quote, because of the coronavirus. And they seem to think that there's a tie in there when that is just a brand name of beer, people. So the coronavirus, which has been renamed COVID-19, is not related in any way to Corona beer. Now, I'm not promoting that you drink it. All I'm saying is that make sure you have your facts straight and it's not fake news or fake information, because that can really not only hurt a company, but it can hurt somebody else as well. So, and you can get just misinformation. So really try to move on from that. I know sometimes you may hear a word or a buzzword that sounds like something else, but really isn't. So always do your due diligence first. Otherwise, you could just really get some wrong information. But in saying that and commenting on my listeners, I just wanted to shout out real quickly to some really positive feedback people that I've been getting this week. Lena, Misty, the Naples and the Orlando chapter AAPC. Thank you. And then also Rose, Natasha, John P, Lisa L, Francis B. I just really appreciate everybody that has sent me either a LinkedIn direct message or something on Instagram. It's just great. And then also my usual suspects. You know who you are. You reach out to me weekly, and I truly appreciate that. So today I have a couple of topics that I would like to cover. One is I've been getting a lot of questions about the new digital and virtual online visits. And it's funny because you can have telemedicine talk about all kinds of different or use all kinds of different language when it comes to talking about virtual visits. But there are some guidelines, some rules that I'd really like to bring to your attention because I see some things being done incorrectly. I know there's some good webinars out there. I know I teach one. Tony Elholmes teaches one through a telemedicine platform for herself. And so there's a lot of different things out there that can give you some good insight into that. But I've just noticed that as I'm auditing records and I'm doing some training, that a lot of practices are thinking they can just have a phone call from a patient and all of a sudden be able to bill for a digital service, and they're not taking in consideration the rules. So just some of the new codes that came out this year I'm going to talk about, making sure that you understand when it's appropriate to use them, when it isn't. They were effective on January 1st, and we're talking about the codes 99421 to 99423. They have time thresholds. They have global days surrounding them. They have certain things about synchronous and FDA-approved patient activated services. So we just want to make sure that you're clear before you bill anything that relates to telehealth in some of the new codes so that you don't get in trouble for it. The other thing is that I'm going to bring up is we're having a 4-part series for the new E&M 2021 coding, and you probably saw it on my website if you frequent it there at terryfletcher.net. But I'm going to have a webinar series, a 4-part for the E&M 2021 rule changes. And it's important that you try to attend at least 1 or 2 of them. It's helpful if you can attend all 4 because you're going to need to train in your office too if you don't bring in a consultant to do that. There are many changes. We're going to have tools for you and timelines and everything. And they start on March 12th. And then we're going to have another one in April, one in July, and then one late in the fall. So make sure you take a look at my website. I'll comment on it later so you know what that will include. But these are paid webinars. These are some training tools and definitely some educational services that you're going to want to participate in to be current and updated. Remember, at the Codecast, I give you tidbits. I give you things that, and I like to call them tools of the trade, that you can take back with you into your office. But there are certain formats and certain parts of information, certain coding information that you really need to have in a classroom format, classroom style, where you're getting a PowerPoint, where you're having, some information that you can take notes on and then bring it back so that you can explain it to your practices as well, or call somebody in, myself or somebody else, to make sure that they can explain it to your physicians and your staff. This is one of the biggest changes that we've had in coding since the ICD-10 conversion, which is now going on 5 years since we've had that. And remember, I-11, so ICD-11 is just around the corner, becoming effective on January 1st, 2022. So we have a lot of changes, updates, new things to deal with, and you want to get your feet wet as soon as you can. Don't put it off, because it's amazing how time flies. So you want to really get started on that. But first, the Codecast is also brought to you by Women in Health Administration of Southern California. It's a nonprofit professional association for women healthcare leaders since 1981. WHASocal.org. Okay, so let's see where we're headed here. Not only am I going to comment on the digital codes, but I also wanted to comment on a free webinar that I'm going to be providing for my sponsor today, Women in Healthcare Administration of SoCal, and it's going to be on April 21st, and it's at noon Pacific Standard Time, so 3 o'clock if you're Eastern Time. But what is interesting about this webinar I'm going to do is I'm going to talk about job market for healthcare. And I'm going to really give you some lists and some job titles and some job descriptions, what's out there, maybe give you a little bit of salary information, talk about resumes, and talk about maybe a recruiter. And I may have a recruiter coming up on my show for an interview. I've never done anything but solo podcasting. I actually shy a little bit away from podcasts that have guests, but I was talking to a recent recruiter and found him through another podcast that I really enjoyed. So I'm definitely considering bringing him on. But stay tuned for that free webinar. So make sure you check it out when it comes out. I'll promote again on my next podcast so you can find it online, but we just did the bullet points today. But I think that might help some of you who are looking for jobs, maybe looking for a career change in healthcare. Maybe think that the only thing you can get is something that you need a college degree for, and we know that's not accurate. So hopefully you'll appreciate some of the information that comes with that. Now, on to the virtual information. So some of the things, and I probably shouldn't call it that, because the virtual codes really have to do with virtual check-in. Medicare created some codes a couple of years ago that talk about, virtual check-in, meaning does the patient actually need to come into the office? And those included G2010 and G2012. And what those were video confirmations or information supplied by the patient to determine whether a visit is required, or a telephone or video check-in with the patient to determine again if a video is required. And one was, does the patient need to come in based on symptomatology from a photo or something they sent to the doctor? And then the other one was, well, look what's happening with me. Should I come in? But there was also some global days around those as well. But those were, since they were G codes, they were really primarily from Medicare. I haven't found that some of the private payers were actually considering them for payment. But what I want to focus on are the new CPT codes that we have for 2020, and these are called online digital evaluation and management services for established patients, and they have time relegated to them. So 99421 is 5 to 10 minutes, 99422 is approximately 11 to 20 minutes, and then 99423 is more than 21 minutes. Now, they're anywhere from $16-ish to $55, somewhere around there, depending on what you're doing. But you know that you do have patients that are saying, instead of coming in and waiting for a visit, can they go ahead and get treated from their own home? Well, traditionally, when we talk about Medicare and telemedicine and telehealth, it has to be where they're in a rural area or in a metropolitan depressed area, as you've heard me talk about before when I talk about telehealth. But what these services are these are for patients who actually can access some kind of a patient portal, or when it has to be initiated by the patient. So it has to be some kind of communication through a secure patient portal or through a secure email or something that has a HIPAA compliant application. So you might see something that is a kind of FDA approved type of device, smartphone that's okay with that, but it has to be something that is HIPAA compliant. And it's something that the physician has access as well. And it's just them going back and forth on this portal type thing. So communication device. But what it's really for is, you've got a patient that is already under care for a clinic, and now let's say they haven't been seen in a couple of weeks. They now think that they've got some kind of maybe UTI, or they've got hypertension that's spiked, or just something that they're not, maybe ingrown toenail, maybe pink eye, and they want the physician to prescribe them some kind of an antibiotic or a steroid or something, and they're not sure what to do, but they really don't want to come in the office or really don't have the time for it. But let's say that as an established patient, at some point they did have something similar taken care of. And again, they're past a 7-day global period out from that initial visit or that visit that was in the office prior to. And now they're saying they've got symptoms that they want to have addressed. And so what they do is they contact the patient. So again, it has to be patient initiated, and they go ahead and go through the portal. The physician reviews the patient's history, maybe their current medications, what they said the last time, and maybe their patient's allergic to something as well. And maybe they send a new script, or they send a new treatment, or pink eye is a big one. I've seen this with pediatric practices quite a bit, mainly because they're also on commercial plans, and that's what happens to be paying for this. So Medicare right now is not always paying, so you need to know what your payer policies are. But they respond through this portal to the patient. The doctor has to document what the eVisit conversation was, again, back and forth. They have to give time. Remember, these are time-based codes. So let's say they spent a total of 10 minutes with the patient. Then they would be able to code the 99421 service. So that, because then you're getting into the specific timed code of 5 to 10 minutes. Again, this is something maybe the doctor is going to do at the end of the day, or maybe first thing in the morning, or at their lunch hour when they get a break. But here's where it gets kind of interesting. So because these are time-based codes, and the doctor does have to document exactly what they did, the time frame which when they did it, you have to make sure that there's some kind of internal feature in your electronic medical record that can track the time. You can put it on a spreadsheet if you need to, but you also need to make sure that the language states that the patient initiated the care. And you also will have to make sure that the physician performed the actual service. They have to be the ones, and this was on the fee schedule, on the final rule, that said that the physicians have to be the one to evaluate, assess, and manage the patient. They can't be the one to just communicate what maybe a medical assistant or a mid-level provider puts in the information. And it can't be a mid-level. It has to be MD or DO. And then again, patients have to be established. Now, can it be a new problem to the physician as long as they're established patient? Yes. And I like this because when telemedicine first came out, if you took a webinar of mine or ever heard me talk about it, one of the biggest things for me, and I know some other companies don't agree with this, but this is just my position on it. I think if you're going to get your feet wet in telehealth or anything that has to do with online treating of a patient, you want to know their history. You want to know that you've seen them in person and actually touch the patient at some point, because that would hopefully negate some of your liability from never seeing the patient, and from a lot of the fraud and abuse that's out there from people using their friend's insurance if they don't have it. And so that's where it's important to make sure that you have had contact with the patient, there's a physician-patient trust there and a physician-patient recognition there as well. And now you could go back in and say you could help with something that they're having a problem with. But also know that the patient visit on this digital platform, it means that it's usually over a period of time. So it can be a possibility of a cumulative situation. There has to be a possible management plan or subsequent communication with the patient, and it has to reflect in the electronic medical record that that's part of that visit. And clinical staff time does not count towards the total time, only the physician's time. And there's other restrictions that you also have to consider when it comes to these visits. If the patient saw the physician within 7 days of the initiation of this patient initiated visit of this digital service, then they cannot report this online. But if it is after that 7 days, or if it's a visit that was new or was unrelated to the problem that they were seen in the office for, then you can report it online. I strongly suggest that you get somebody in your office who's a point person and have them look at these codes and then do a bullet by bullet point of yeses and bullet by bullet point of no's. So when you can bill it and when you can't bill it. And I think this is going to be a really important aspect of building some revenue in your practice that you didn't know you could have, especially if you are a practice that has a patient portal. And remember what patient portals are. They're attached to your electronic health record that allows patients to see lab work, to see x-ray results. It's very limited on the scope of what they can see, but it also allows them to pay their bills online on your website. And so when patients can access that, sometimes patients are not aware because your practice hasn't marketed or told them that you offer any kind of digital or online services or telehealth services. So it's important that you also let the patients know that this is an option, but also let the patients know that it's not necessarily free. Now, I have insurance that if this is something that I want to have with my physician, my commercial plan doesn't charge me a copay or deductible. So for me, it would be free. But you have to make sure that some patients understand that it's not necessarily no share of cost, which brings us back to something else. You have to get a consent because a lot of patients aren't usually familiar or are accustomed to being charged with a non-face-to-face service. And so you have to get a consent for anything that you do offsite or non-face-to-face. But Medicare now permits physicians to get a single annual consent for any kind of communication technology-based service. And so they put that out last year. It's so the patient doesn't get unexpected medical bills. And you've heard about that surprise billing that hospitals are dealing with right now. But it really is important to know that the patient has to consent not only to the care, but also to the billing. And so when they came in, that's why it pertains to established patients, because there's an assumption that when the patient comes into your practice, they're signing a consent for everything they're having. This isn't the same thing as a waiver, which it's not a bad idea to get that signed if you're not checking to see if there is coverage. That's something that's up to your office workflow. And if you're just saying that you're going to trust the patient that they have coverage if they're a commercial plan, that's up to you. But you want to make sure that you at least have those consents signed if the patient chooses to utilize your non-face-to-face services. And the time to do that is when they come in face-to-face to have that signed. And make sure that your consent includes billing. Sometimes a lot of the consents just says that they're allowing you to see them or to treat them, but it doesn't also consent submitting it to an insurance company and their responsibility for their share of cost, should there be one. So that's a really important aspect of this. But I wanted to just touch on these services because I see practices, and the biggest downfall is that they're trying to bill for these within that 7-day time frame. So a patient came into the office, they had a rash and they went home and they got cream or ointment or topical prescription. It didn't work after 4 or 5 days, and then they go through the portal or they call the office or some digital communication means and saying that, can I get a different antibiotic or a different type of topical because this isn't working. and the physician gives it to them. It's documented well, but unfortunately, they haven't met the criteria for the guidelines. So it was in a 7-day period, which means you can't code for it and you can't report it. So know those rules and know those guidelines. Otherwise, you could be reporting for services that are not accurate. So we've got to just make sure that we're on top of it, make sure we're following the rules. And again, do a yes, you can do it. No, you can't if you're going to start bringing these services into your practice. And I strongly recommend that you do. A lot of practices are already starting to do telemedicine and telehealth and are way past, just thinking about it. And so you want to be competitive in that market as well. Otherwise, you may get left behind on what's going on with new digital services. So before I get to my personal tidbit today, I did want to also comment on some of the things that I was going to be talking about with the WHA free webinar. One thing I noticed that on the job market in healthcare, I've noticed that as I was doing some research on this, there's some things out there and some jobs I should say out there that don't require a bachelor's degree, maybe a high school diploma or equivalent. Home health aides, personal care aides is one of them. There's something, nuclear medicine technologist. You can be also, there's a couple of things that I thought was interesting. One was called a recreational therapist. And the amount you start at is around 47 a year. But these are therapists that plan, direct, and coordinate recreation based on treatment programs for people with disabilities, injuries, illnesses, or geriatric population. So there's all kinds of things. There's social media people out there that are dealing with medicine as well. So there's promotional healthcare employees. But if you're interested in just hearing what are your options and what are the possibilities, make sure that you do tune into that. Okay, so my coding question for the week comes from my orthopedic practice that I have in Oregon. And this is an interesting question. She says, "Hi, Terry, hope this finds you well. We have a question regarding services that are considered investigational or experimental. For example, 0232T for PRP injections and stem cell injections. Do we have to notify patients of the FDA that they consider these types of services as experimental and investigational? And should we have them sign acknowledgement to that effect? Also, since we know they are investigational, is there a point even billing the carrier because we know this isn't always payable?" So my response to that is yes, you need to have the patient sign some kind of a waiver. Actually, I don't want to call it a waiver unless the waiver is for payment and you are going to report it to the insurance payer knowing that it may not get paid. So it's a waiver so that the patient knows that they will be having their out of pocket. But anything experimental or investigational, yes, the patient needs to understand that it's not FDA approved, that they still want it, and why your physician feels it would be effective when it's not on the formulary or it's not on the list as being an approved service, treatment, or anything like that. So it is important just for your own liability and malpractice protection to make sure you get that. But the one thing to be careful of is make sure that if you do report it to the insurance company with that T code and you know it's not a service they cover, that you can't write it off. The patient will have to pay for it because always remember, we bill what we expect to get paid, not what we hope to get paid. Otherwise, it's considered a false claim. Now, my personal tidbit for today is I wanted to comment on something that I've done webinars on professionalism and information as far as just really how to clear your mind of things. And one of the things that I talk about all the time is write it down, make lists. You can't remember everything. I make a list every single night. I saw something on LinkedIn where APC put something out. There was one of their pro tips, number 2, that said, make a list of what you need to do, your 10 top things you need to do the next day. I know that Tony Elholm's on her Alpha Coders podcast, that she said something similar in one of her podcasts. But I've been saying this for years. But the reason I wanted to bring it to your attention this week is my daughter, Summer, who is a softball coach for high school. She was having a hard time with her practice because she was going off the top of her head as far as what she wanted to do with her players when she did a practice every day. And now that they're in season, she said it wasn't going well. And I said, well, you have two assistant coaches and the girls can read. They're in high school. Why don't you write down your plan for the day and each day and what they're doing first, what they're doing second, and also have a plan for, pre-warm-ups and games and post it in the dugout. That way, all they have to do is look, and then they get their stuff out of their bags, they go set it up, and they get out on the field and start right away, and then you won't get frustrated. And she started doing that and made up her own schedule, her own platform as far as what she wanted to get done. And she says, I feel stupid. How did I not do that before? She said, when all I had to do is write it down and the girls can know what we're doing every day, and it gives them some consistency, because some days will be the same, Monday, Wednesday, Friday, but Tuesday, Thursday, maybe we do pitching or hitting. But it's the same thing as you apply it to your job in healthcare. Write it down. We get to cross things off every day, even something tiny like reminders to call that insurance company, or make sure you staple that report to that appeal you're doing because it has to be by hand, or making sure that you email a physician on a query. Something like that you want to have on your list so that you can make sure that you could cross it off at some point. And I have a pad and paper with me all the time, mainly because I'm tired of always opening my phone. I'm getting kind of annoyed with myself with how much my phone is attached to me. And I think sometimes you'll probably get sick of your phone as well, especially because how easy it is to pull up Instagram or pull up Facebook or pull up some kind of a social media account, and then you lose focus on what you're trying to do, for your daily work. So write things down, try to make sure you're making a list, and hopefully that will, help you clear out your mind for the day. So thank you everyone for listening. We appreciate all of our listeners and all of our downloads, and I hope to see you soon. And remember to go to my website at terryfletcher.net and check out some of our latest webinars and educational offerings. We're happy to have you, and you'll see we have some good stuff up there. So thank you. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.